how do we evaluate these patients on the eye exam? And so these are the key components that we'll think about: visual acuity, color vision, pupils, visual fields, motility and alignment, eye pressure, and then the actual eye exam of the eyelids in orbit, anterior and posterior segment exam. And all of these things together will help us identify and localize the problem and come up with a differential for further evaluation. So for color vision, we either use the Ishihara or the HRR color plates. And this is because optic nerve processes often preferentially decrease color vision as opposed to retinal processes. And so especially with someone, say, like optic neuritis, they may have some decrease in acuity, but a marked decrease in their color vision. And this can help us differentiate between those optic nerve and macular causes. Pupil testing, we want to look for an afferent pupillary defect. This oftentimes is the only objective finding of vision loss for an optic nerve process if it's posterior. And we may not see any abnormality of the optic nerve in the acute setting. Remember, acuity and color vision and confrontation visual fields are all subjective portions of the exam, but the pupil, the afferent pupillary defect, is really potentially the only objective finding. Remember, an afferent pupillary defect will not give you anisocoria, but it's important to also look for anisocoria because that may help localize, again, if you have pupillary abnormality and optic nerve process that may localize to the orbital apex. This is just a reminder that you only need one good working pupil to be able to evaluate an afferent pupillary defect. You can actually look for a response in reverse. If you swing the flashlight over to the constricting pupil and you see a response, you can determine what is going on with the dilated pupil as well. When we look in the back of the eye, primarily at the optic nerve, as I'm not covering retina in this talk, the optic nerve really can only do a few things. It can become swollen, it can become pale, or it can become cupped. And so for cupping, that's usually what we think about for glaucoma. And so oftentimes when we're differentiating between glaucomatous and non-glaucomatous optic neuropathies, we're thinking about the degree of cupping versus pallor on the optic nerve. But in the acute setting, we're often looking for edema of the optic nerve and then, progression to pallor. Pallor will not necessarily show up initially when you have an acute process, but does potentially take weeks to months to occur. Pallor is typically kind of the end result of any optic nerve process, and so doesn't necessarily help guide you in terms of the underlying process, other than we typically don't see pallor in glaucoma, but rather cupping. So here's an example of disc pallor. You can see this side is a fairly normal appearing optic nerve, but you can see some pretty significant pallor temporally here. And you may be able to appreciate that there's a difference in the appearance of the nerve fiber layer, where you don't see the same degree of nerve fiber layer here as you do here, given there's some dropout here. And that could be more apparent on red-free imaging. And so here's an example of disc edema, where you can see that there's elevation of the optic nerve, so we call anteriorization of the optic nerve, where you can see these vessels kind of come over the optic nerve head. We can see kind of this grayish white thickening of the nerve fiber layer that occurs with edema. You can see there's cotton wool spots, flame hemorrhages, and then most importantly, we see obscuration of the vessels at the margin and also in the peripapillary area. These findings are important because sometimes we're trying to differentiate between true edema versus pseudoedema or pseudopapilledema. And so oftentimes with pseudopapilledema, the nerve may appear elevated, but we don't see that obscuration of the vessels that we expect to see in true edema. And so this is an example of papilledema, which we reserve the term papilledema specifically for disc edema that's secondary to increased intracranial pressure. And so if you use the term papilledema, you're implying that the pressure in the brain is elevated. If we're not sure if it's from increased intracranial pressure or if we believe it's from other causes, we prefer to use the more general term of disc edema. So moving on to visual fields, we have a few different ways to evaluate visual fields. There's confrontation testing, Amsler grid, and then perimetry. there's a few different ways that we can do confrontation testing, depending on the patient's ability to participate. You can just simply ask the patient to describe the examiner's face. Sometimes I'll say, can you see if you look at my nose, do you see my entire face? You can do finger counting in the 4 quadrants. You can actually use a red cap from a dilating drop and move it and see when they're able to identify it. And then one that's, I think, actually a pretty interesting one is a red cap comparison, where if you have the patient look centrally and you have a red cap on either side, so nasally and temporally, and you ask if the brightness of the red cap is the same. And this can actually pick up early temporal depression, like a bitemporal hemianopia, if they say that temporally the red cap looks duller. So these are some kind of easy ways that you can do confrontation testing. AMSA grid testing is actually a pretty quick way to assess for the central 10 degrees, and can also pick up metamorphopsia or small scotomas that may be hard to pick up on formal perimetry. And then there is formal perimetry, which we divide up into kinetic and static. So kinetic is done manually, what we use for Goldmann perimetry. And then static is the automated perimetry that most commonly used is the Humphrey visual field. And so here's just a image showing the difference between kinetic and automated. And so our typical 30-2 Humphrey visual field measures 30 degrees of center in all directions. So it's just this very central part of the visual field. Whereas kinetic perimetry actually assesses the entire visual field, which is typically about 150 degrees. And so we can get 90 degrees temporally and 60 degrees nasally. And so there may be some benefits to doing kinetic testing as opposed to automated. But most deficits we can pick up with a 30-2 or even a 24-2 on an automated field. So how do we interpret the results of an automated field? So here's an example of a 24-2 Humphrey visual field. And so there's lots of information on here. And so we want to kind of take it in a stepwise fashion. So up here we have the reliability indices. And so this tells us how reliable the field is, how well we can interpret the information that's given. And so we have fixation losses. And so this measures actually the number of times the patient is noted to be not looking at the fixation target when tested. And then we have false positive and false negative errors. And so if someone has a high false positive error percent, the field may actually look better than it truly is, because they're pressing the button more often than they should. Whereas with false negative, they may be not pressing the button when they're expected to, and the field may look worse than it actually is. Then we look at the foveal threshold here, and this is the threshold sensitivity in the fovea. This is normal at 36, and this gives us some kind of rough comparison to the acuity. And so a normal acuity should have a normal foveal threshold. And then we have our threshold sensitivity plots, and this is actually the information that is given, obtained from the field. This is the raw data. Then it's created into this grayscale plot, which is basically the computer interpreting the information to give a general pattern of abnormality. And so this actually creates more information than is actually taken from the patient's test. And so I would caution you when looking at the grayscale that you may falsely interpret information that's not actually obtained from the test. We prefer to look at the total deviation and the pattern deviation, because this is just taking from the raw data. And so the total deviation basically is from age-adjusted normal values at each point of testing. And then the pattern deviation basically adjusts for overall depression of the field. So really highlights the areas that are primarily abnormal. And so this can be helpful if a patient has a cataract and also an optic nerve problem. It's going to remove kind of the generalized depression from the cataract and give you the true areas of depression from the optic nerve or posterior visual pathway process. And then we look at the mean deviation, which basically it's the mean of all values in the total deviation plot. And so this can be something that you can kind of track over time to compare studies. So a lot of information. I think really kind of the take homes are make sure it's a reliable field, that the foveal threshold kind of matches the acuity of the patient, and then avoid the tendency to just look at the grayscale, but actually look at more the total and pattern deviation to get a sense of what the actual visual field loss is. There's a number of adjunct testing that can be done. I'm not going to go into all of these into great detail, but we have contrast sensitivity, which can be a more sensitive way of acuity measurement in patients with optic neuropathies, especially optic neuritis. Photostress recovery testing, which can be helpful in differentiating optic nerve and macular pathology. Potential acuity measurement, which can be helpful in patients with reduced vision from cataract. And then we have angiography, including fluorescein and ICG, autofluorescence, OCT, ultrasounds, and electrophysiologic testing. And I'll go through a few of these in more detail. And so trying to determine kind of what the utility is of these different tests, it's important to kind of understand what you can potentially gain from doing the tests. The fluorescein angiography is kind of our most common invasive test that we can do in the office. And this can help us look at the retinal circulation, and then in terms of the optic nerve to see if there's leakage of the optic nerve when we're evaluating disc edema. ICG may give you more information in terms of the choroidal circulation. It's less available and takes longer to do. Fundus autofluorescence is non-invasive. It does not require an injection of fluorescein. It can give you some quick information in terms of RPE, and also when we're evaluating for possible disc drusen. OCT has really become kind of the mainstay of imaging in the clinic, and we'll go through some examples of optic nerve pathology. And then ultrasounds from an optic nerve standpoint can be used for evaluating for disc drusen, potentially papilledema, but then also more posterior pathology in the retina and choroid. So here's an example of a patient with giant cell arteritis. There's delayed choroidal filling, which is a pretty, and so if you see this in someone, this is a patient with visible disc drusen here.